So good evening, everyone. First of all, Prasad, thank you very much for that master class. I was glued actually, and I was surprised, the amount of literature and the concepts you kind of covered in a very short span of 35-40 minutes. So it was really a comprehensive view.
Thank you.
So we were,
I should thank Satyendra for giving me some slides, which was helpful.
So we move on to the second half of today's session, and we have Dr. Vipin Khandelwal, who is a friend and colleague from Mumbai. He is a senior consultant at the Apollo Hospitals, Mumbai, and he's going to be moderate a session on GVHD, more in the tune of practical aspects and also some of the questions which were just raised. So Vipin, over to you, and you can introduce your panel and go ahead with your panel discussion. And for everyone else who has been logged in, please post your questions in the chat box, and we will be more than happy to discuss them with the panel after the panel discussion is over. Over to you, Vipin. Thank you.
Thank you, organizing committee, and thank you, Dr. Prasad. I think you have discussed everything about GVHD profile access. So, but I will share some cases, and we can discuss about more about how to use other medicines for GVHD profile access. So, am I audible?
Yes.
So I am having the esteemed panelist, Dr. Prasad. Dr. Garima is also here. She's from Apollo Hospital, Delhi, and Dr. Vinay is associated with Manipal. I'm sharing my screen now.
I'm going to rest my throat. I'm going to let you guys do it.
No, we will not leave you. We want more inputs from you. So, uh, my screen is like visible now.
Yes.
Okay.
Yes.
Okay, so like without wasting time, I'll move to our first question. So this question was shared by Dr. Kateva to me. Like this child is having a severe aplastic anemia, and he was given ATG, and after ATG therapy, this child went into acute kidney injury. So the child didn't respond to ATG, and he developed acute kidney injury, and now he's having one mass sibling donor. So, in this scenario, what will be your preference for GVHD prophylaxis? So, Dr. Prasad, over to you. So, when any patient who is severe aplastic or any other condition now having acute kidney injury, and you are going to do transplant with a mass sibling donor, so what GVHD prophylaxis? What will be your preference in such cases?
Um, Quick question. What is the glomerular filtration rate? Only give me a creatinine.
So it was like, you can say it was very less, and it was like creatinine is also more than 2.
So more than the GVHD prophylaxis, what conditioning are you going to use is going to be a problem, right? So that is also going to affect your kidney function. So you have to choose very carefully what you're going to do with your conditioning also. It's not just GVHD prophylaxis. Again, if you have, remember our EBMT data, EBMT recommendations, if you really cannot use anything, then you will have to use MMF or sirolimus, right? Sirolimus, as far as I know, is not that nephrotoxic. So that would be one of your strategies to use. So that would be there. So yeah, those would be my two considered agents that I might use for that.
Okay, so one more thing you
But
can.
more importantly, I would prefer to use a strategy of depleting grafts with alpha beta or something, even though it's a matched sibling donor. Because
Yeah. So Dr. Kateva, he did alpha, beta, and B cell depletion, and the child is doing well. So this is
excellent.
one thing which we can do in like those who have acute kidney injury. So this child is having transfusion dependent thalassemia, and underwent a mass sibling donor transplant, and standard GVHD prophylaxis was used, which was cyclosporin with antimetabolite, and that was methotrexate. So ATG was also used just to for GVHD protection. So Dr. Vinay, like just ATG is like a standard thing which is used in unrelated donor transplant. So what is your strategy for the mass sibling donor transplant? Are you using ATG always, or you have some preference, like in benign disorder I will use and malignant I will not use? So just over to you, please help
Yeah.
us.
So in match sibling setting, there is a little contention, especially in low risk patients, whether to use ATG or not. But definitely class 2, class 3 math sibling, I would use ATG. Even in a lower risk class 1, probably I'll use a low dose of ATG to prevent, one is for helping the prevent graft rejection, at the same time help with GVH prophylaxis as well. So it is institutional practice. I think most of us now are using a little bit of ATG in math sibling setting as well in thalassemia. Yeah.
Yeah, so like, is there any preference for you in the calcineurin inhibitors also? Like, whenever you are doing any mass sibling donor transplant and you are giving myeloablative conditioning, so like tacrolimus or cyclosporin, sometimes we people are confused like what to use. Dr. Prasad has discussed like both are okay or it's a institutional practice. So is it like that, or you follow something different?
Yeah, I think with going with the guidelines CNI plus methotrexate for math sibling, in the CNI, we would prefer more using cyclosporin mainly because of the IV formulation that is available in India. TAC doesn't have. Levels are easily available. I know many institutes are using tacrolimus as well, and fairly we are compared to a decade ago. Probably now tacrolimus use is better. Personally, I would consider cyclosporin tacrolimus as my combination, and I think it is more of an institutional practice, and we have evolved with our experience.
Okay, thank you. So now this child is had GVHD also and was on steroids, and this child now developed press. So what will be your GVHD profile? Like, you cannot stop GVHD prophylaxis if someone is having GVHD. So in this case, like you are having press, maybe secondary to the calcineurin inhibitor. So what will be your steps which will help this child, and what GVHD prophylaxis you will change now? And similarly, like sometimes we develop the transplant associated TMAs also with the calcineurin inhibitors. So what modification you do in such scenarios?
Yeah, so firstly, with regards to press in this child, day 30, the child has had the problems. So what I would do is stop CNI for 48 hours, continue low dose steroid with good antihypertensives. Probably I'll try switching the calcineurin inhibitor, and many times with our experience, it has helped. So that we continue, if it is on cyclosporin, go to tacrolimus plus steroid. Absolutely stopping cyclosporin or tacrolimus for press alone is not practiced, and especially press being a acute event, the child gets better in 48 hours with good antihypertensive and good intensive backup. Probably I would restart calcineurin inhibitors, but will change it to another one. In situation of TMA, it is different. I would definitely stop off the calcineurin inhibitors. Probably something like MMF would be necessary in such a situation with low dose steroid and as a prophylactic measure. If GVHD is ongoing, then it's a different issue. GVHD triggers TMA, TMA triggers GVHD. So we'll have to control GVHD well. Something like ruxolitinib or something like that has to be used in such
Okay,
situation.
thank you. So Dr. Prasad, you agree with the same thing, or you follow
Um,
something different?
I don't, we don't actually, if you have a press or if you have hypertension, then we tend to actually completely stop the CNIs. We don't switch. It's just institutional practice. We will probably go for low dose steroids with ruxolitinib and add MMF if we need be upfront. So that would be our way of doing it. We don't challenge again with CNI.
Yeah.
Again, institutional practice. I'm not saying what Dr. Vinay is saying is wrong.
Okay, thank
Yeah.
you. So CNIs, they have some side effects, but they are very good immunosuppressive agents. And but yes, the one thing is like they have a poor immune tolerance, and immune tolerance is very important for the long-term effect and GVHD free period. So here comes the roles of the new agents and the newest strategies. So this case was shared by Dr. Garima only. Like this child is having a sickle cell disease and underwent matched sibling donor transplant, and the GVHD prophylaxis which they use nowadays is the post-transplant cyclophosphamide with sirolimus and MMF. So this child was doing well without he was having only a grade 1 GVHD, and the immune reconstitution was also good. So Dr. Garima, yeah, the PT-SI, like it was started with the haploidentical transplant, but yes, the role is also evolving for the matched sibling donor unrelated donor transplant also. So like what is your experience with this strategy, and what advantages made you to shift your prophylaxis to completely to the PT-SI even in the matched sibling donor settings? So because there are some concerns about the PT-SI with the hemorrhagic cystitis, they can have cardiac toxicity. So what any modifications you do in your protocols, or can you please just tell?
As Prasad sir has mentioned that BMT CTN 1703 trial, they have found superiority of using PTCY with TAC MMF as compared to tacrolimus and methotrexate. And there was reduction in the both acute GVHD and chronic GVHD. In our institute, we use peripheral blood stem cell as a stem cell source. So that is a risk factor for chronic GVHD. So for all of our HLA matched sibling donor and mud donor transplant, we use PTCY with sirolimus and MMF. So we used to use 50 milligram per kg for 2 consecutive days. But for the last 10 to 15 patients, we start using 25 milligram per kg for 2 consecutive days for matched sibling donor transplant. And in those 15 patients, we did not found any acute GVHD. Still our follow-up period is short, so we cannot comment on the chronic GVHD. And as you have mentioned that apart from the traditional toxicities of cyclophosphamide, which is cardiotoxicity, nausea, vomiting, and hemorrhagic cystitis, the other toxicities like cytokine release syndrome, but it is comparatively low in matched donor transplant as compared to haploidentical transplant. There might be increased risk of, there might be delayed engraftment, but in our cohort, we did not find any significant difference in the engraftment kinetics between the cohort which was receiving PTCY and the as compared to our historic cohort. So we have shared our data in SPECT meeting. So we have given this PTCY sero MMF in 66 patients, and our rate of acute grade 2 to 4 GVHD was 3% and chronic GVHD was 1.5%. For our patients, it's working quite well.
Okay, so
I want to say something. This is Dr. Satyendra.
Yes, sir.
yeah,
So when you are using Plerixafor
Yes, sir.
for donor mobilization,
Yes, sir.
that is also a kind of a GVH prophylaxis because your whole graft composition is different. Now, in patients where you are using GCSF and Plerixafor, and then you are decreasing the dose of PTCy, we are not sure whether the not increase in GVH is because of the composition versus the dose of cyclo doesn't matter, because these are the two things. So I will put a slight caution here that we need to have this data, because the traditional way of doing PTCy was the GCSF, and now I agree with this GCSF and Plerixafor also. It's an amazing way of mobilizing the donor. So please, there is a big thing which we should be very sure before somebody listening to us and start doing it in just GCSF mobilization. With GCSF, this data is not there. This is GCSF plus Plerixafor, and then there is a different ballgame. So I just wanted to clarify it slightly more. Sorry,
Yes,
Vipin.
sir. Yes, sir.
so Dr. Prasad, any inputs from your side? Like your center is doing like PT-SI prophylaxis for
No,
the matched sibling donor or the unrelated donor transplants, anything?
no, we don't do PTCY for any of the matched siblings or matched unrelated donors yet. Yeah, so I would defer to you guys with more experience on this. But I have seen some data coming where they have dropped the doses of PTCY on day 3, day 4 in patients with matched sibling donor transplants. So yeah, I agree with Karima that the data seems quite robust. They should publish this.
So this was like one review article in Blood Advance and recently published only, and they shared the results of PTSI based GVHD prophylaxis for mass sibling donor transplant, and PTSI was found to be have like beneficial in GVHD prophylaxis, and uh, uh, but it is not used as a single agent. It needs to be used with some other immunosuppressive agent, and uh, like any role of adding ATG when we are using PTSI, Garima? Anything like that? Like, because this data is showing like adding ATG will increase the CMV and EVV reactivation without improving the GVHD and the relapse-free survival. So, any comment on that?
So we do add ATG, that is grapholone, but we use a very low dose, that is 10 milligram per kg over 3 consecutive days, because that helps us in addressing the graft rejection also. Because most of our patients are transfusion dependent anemias, thalassemias, and so we do use low dose of ATG, but we did not find any increased risk of like viral reactivations or other problems.
Okay, so a word about Aptasep. This is also one new molecule, and this child received unrelated donor transplant, and the conditioning protocol was the myeloablative conditioning, and the GVHD prophylaxis consisted of Aptasep plus tacrolimus and methotrexate. So the Aptasep was used for like 10 mg per kg dose on day -1, day +5, and day +14, and day +28. So, Dr. Vinay, like, do you want to tell us about what is the mechanism of action of this Aptasep?
So as already Prasad sir did an excellent description of all the newer agents. So mechanism wise, it actually it is a blockade of the co-stimulation of the T cell, the second signal that Prasad sir showed. So basically, the effector T cells are will not continuously start proliferating. So that is like a more target towards the T cell effector cell pathway. It doesn't as such increase T regulatory cells, but overall, when the effector cells come down, the profile of T cell armamentarium slightly changes. So that is the mechanism. Personal experience with abatacept, I do not have any.
Like, and can you just tell us more about what are the advantages of using Abatacept, because so much trials are going on this, and the data is also there. Like, it is very helpful in preventing GVHD, especially the acute one.
Yeah, so the data that we already saw in the talk showed excellent responses with the acute as well as chronic GVHD, bringing it less than 5% as against 20-30% in the general thing. We can also avoid toxicities of the prophylactic measures that we are using now, like calcium inhibitors. They come with steroids, and I think the overall usage of steroids will come down when we have such a good anti-GVHD prophylactic measure, which overall decreases the viral reactivations as well. So these are the advantages, and I think most of the centers in the West, especially US, North American group, utilize abatacept as the backbone in the GVHD prophylaxis.
Correct. There is Indian data also. Dr. Sarita Jaiswal has published with the use of abatacept and PTSI and sirolimus in haploidentical transplant in the non-malignant disorders also, and they have used it like on day 0, day +5, day +20, day +35, and then monthly until day 180 post transplant. But they have used with post transplant cyclophosphamide and sirolimus, and the GVHD and event-free survival was very good in even the benign disorders. So now we have ATG also, which can decrease GVHD, especially the chronic GVHD, post-transplant cyclophosphamide also, abatacept also. So like so many molecules are there which can be helpful and which can be added to the standard GVHD prophylaxis. So what will your take on this, Dr. Prasad? Like, nowadays, like if we have to do some mass sibling donor transplant, so what will be your preference, the same standard one, or you would like to use something more?
I would not say the standard one is good enough. I think the standard has changed because we see a lot of GVHD with matched sibling donor transplant. So it depends on your center. What is your preferred choice? That would be one. I mean, if I don't know how expensive abatacept is in India. Is it very expensive?
So like I do not
Yes,
have
it
any
is. It is quite
It's
those
expensive.
values can give
I mean,
comment.
per transplant, it will cost you additional around 6 lakhs.
it's not registered yet in India, Prasad. So you have to be imported on a patient assistance program. It's expensive,
Okay.
very expensive.
So then your answer is obvious. Depends on your patient's diagnosis and condition as well. But generally, then I think the preferred choice would be PTCY. One very important take home for especially people who are training or junior is that, the original Leo Luznik protocol for PTCY was based for bone marrow grafts. We are doing PTCY in India in a lot of our patients with peripheral stem cell grafts. And we all know, right, that the T cell inoculum dose is 1 log higher in your PBSC than in the thing. So you have to be very careful when you interpret Leo's Luznik or papers and directly put it into our patients. It's not, because our grafts are different. So you have to be very careful, when you take this board. This is just a, FYI, important to know. We can't just blindly copy things because we are doing it a bit different. So yes, then if it's a mud or MSD, then maybe PTCY is the way to go. Would be my take on it. But again, it is all patient dependent. It's individualized. It's also dependent on what condition they have, what is their clinical condition.
Okay. So, Dr. Vinay, Dr. Garima, any comments from you for this thing? Like, would you like to add PTSI and abatacept in the standard prophylaxis? Garima is already using the PTSI one. Vinay, from your side, anything?
Yeah, so from my side, I think in standard conditions, ATG PTCY is a good combination. That also is new. We need more evolving evidence, ATG plus PTCY. Abatacept, I would be more keen to use in conditions like PID transplants, where already there is a lot of viral reactivation, that is their onboard viral things. Maybe in a situations, it may be better. A small child, less than a year, where drug toxicities are more. So that I think we need to have some form of uh, categorization of use of abatacept, especially because of the logistic reasons. But with evolving evidence, I think we may go more towards targeted anti-GVH prophylaxis than using conventional chemotherapeutic agents or a broad spectrum steroid kind of anti-GVH prophylaxis. So we will evolve for sure, but at the point, abatacept may be reserved for specific categories.
Okay. Dr. Satya, Dr. Satyendra, Dr. Sunil, Dr. Gaurav, any comment from you for this thing, like, or message to the juniors?
So, I mean, hi, Vipin.
Hi, Dr. Gaurav.
Yeah, thank you. So first of all, wonderful session, Prasad. Thank you so much, and equally good moderation by Vipin. So I think there are a lot of strategies as Prasad has taken us through. So conventional approaches and the futuristic approaches. Obviously, we should gear ourselves for any sort of futuristic approach which gives us a better GVHD control. But simultaneously, at this point of time, I think a large part of our treatment is driven by making the treatment cost effective. So basically, efficacious, safe, as well as cost effective. And when we talk about cost effectiveness, I think PTC5 plays a very, very important role. Uh, 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 Talking about the dosing, so yes, there's a lot which people are trying to do by modulating the dose in sibling donor settings, in unrelated donor settings, bone marrow as a source, PBSC as a source. So that will we'll get to know as more data will mature. But personally speaking, I feel PTCY is the way to move ahead. Even in the sibling HLA identical donor settings, we've been using it for past 7 to 8 years. Even before 1703 trial, we have been using PTCY for our sibling and unrelated donors. It has just phenomenal outcomes.
Okay, so this is one paper which I want to discuss, like published in Blood Journal 2024. They have they have compared ATG, whether using ATG as a prophylaxis or whether PTSI or whether the Aptacept. So in the 7/8 matched unrelated donors, and they found that yes, definitely Aptacept and the PTSI, they are better than the ATG group. And if they compared Aptacept with the PTSI, they found that Aptaset is having, like, if you can see in this graph, it is better, but it was not like statistically significant. So PTSI and Aptaset, if they are using like in the protocols, they are having showing the GVHD prophylaxis, the role and everything is like better, it's same, but they are better than ATG. So this is something new which I was not knowing. So any comments from Dr. Prasad or Dr. Vinay or Dr. Garima for this thing, like um, PTSI and Eptaset, they are better than ATG if we are using for the GVHD prophylaxis, anything like that you have seen in your.
This paper, Dr. Vipin, but this is overall survival. Is there any data on GVHD in this paper?
So this was like a oral presentation abstract only. So I thought I'll share this thing. So in the abstract, it was written like the overall survival was better because the GVHD and everything was better.
So if I permitted Vipin, see, everything comes at a cost, right?
Hmm.
So we don't have to look at just GVHD prophylaxis in isolation. So it's a whole gamut of things. It depends on what disease we are treating, what condition has been chosen, what graft has been selected as a donor. So, as Prasad rightly said, we can't compare marrows and PBAC data, and that's what unfortunately we most of the times do. We mix up the two graft sources, and the data are completely different. So abatacept is a dream drug actually. So if the cost is not an issue, which if we leave the cost aside for some time, abatacept is a dream drug because it does its job as a very effective GVHD prophylactic agent, and that too in a match setting, just with CNI and methotrexate, right? And in haplo setting, of course, in the haplo backbone, the GVHD rates are very, very low. And what is magic is that it doesn't increase other complications which are significant, and especially infection risk and immune reconstitution. So, when an alternative, for example, PTCY is used, it's cheap, so that's an advantage. It's very, very, very easy to administer. That's an advantage. But we have to also remember that immune reconstitution does get affected. So immune reconstitution is slower in the PTCY group as compared to a non-PTCY group, especially if you look at the matched sibling or match related donors. I think MUD is something which is still exploratory, and probably there may be some role in MUD donors, but in matched sibling donors, it does increase your immune reconstitution is slower. It does increase your infection risk. It does increase the risk of hemorrhagic cystitis, which can be sometimes quite significant morbidity, if not mortality. So I think we can't conclude that in a match related setting. I don't know why people still shy away for using marrow as a graft. Marrow still is a good graft. It by itself is a GVHD prophylactic agent, and it has been shown on pediatrics in many series that marrow even in malignant settings is a better graft than PBSCs. In terms of overall survival, GVHD-free survivals, and other things. So I think to answer your question in short is that it depends on what disease, what conditioning, what's available, what's your institutional practice, and if we just look at science, abatacept is really promising. And if I think you or someone showed the graph, that data of 2% GVHD rates, which is kind of nothing actually. But again, as I said, cost is an issue and availability is an issue for us. PTCY MUDs, of course, exploratory. We still cannot probably just kind of take it as a standard of care yet. But yes, emerging data. Match related donors, I'm not sure. I think we have a good GVHD prophylactic backbone already, which is being used. And if you use a marrow graft, I don't think the GVHD is of that much of a concern with a marrow graft. Thank you.
Right. Thank you, Dr. Sunil, for summarizing everything. I think there are so many factors behind GVHD, and just GVHD prophylaxis is not only like giving immunosuppression and other thing. So, like, we have to manage the conditioning also. We have to check like who is the donor, everything. So, I think that's all. Over to the organizing team again.
So thank you very much for that lovely panel discussion with really practical day-to-day scenarios and questions. We have few questions in the chat box, and that is, if I start from the first one, tacrolimus or sirolimus, which after press to be given? That is one question. Anyone wants to take it? Vinay, you want to take it? I think you discussed
Yeah.
that. I think
I think it is not a standard to switch, as Dr. Prasad told. So basically what we have done is cyclosporin to tacrolimus, and there is also a publication from Revati ma'am where they have commented in thalassemia transplants that I think in mud transplants of thalassemia where the incidence of press was more, switching of CNIs help. So sirolimus is like if there is TATMA, definitely sirolimus works synergistically to worsen the condition. So switching from cyclosporin to sirolimus again goes with the experience of the center to use sirolimus plus MMF or sirolimus plus steroid as a GVH prophylaxis. Yeah, that's my take.
Prasad, ruxolitinib as prophylaxis is another question.
I think that is what I was talking about. There is data from
Russia.
uses ruxolitinib as prophylaxis with good agents. There is no difference in the dose; it is the same dose. So they have shown some data that can be used for prophylaxis.
In marrow source is used. Is Ajita asking this question? In a marrow source, is PTCY practiced in matched sibling donors? I think Vipin, Garima or Vipin, one of you wants to take this question.
So we use it in a peripheral blood stem cell source, not in a marrow stem cell source.
And I think that's what the practice has been. Wherever the data on PTCY is in a matched sibling setting is with the PBSC. So be cautious with a marrow graft. If you are wanting to use, I think this is something to be cautious about. There's no data in a marrow graft with PTCY. Rahul is asking a question: what are the selection criteria for doing MSD and PTCY? I think a lot of interest in PTCY, matched sibling donors. So I think it's been kind of discussed already. I think we'll skip this. Anvita has asked a question: do we need to reduce the dose of PTCY if we're using posaconazole prophylaxis?
Probably we can start posaconazole from day 5 rather than after giving the PTCY. Before that, we can cover with liposomal M4 twice weekly like that.
And do we cap the T cell dose in the PBSC graft? Is anyone capping the T cell dose?
Yeah, I think that is a good strategy going forward to cap the T cell dose, especially because we use a lot of PBSC grafts. Capping the T cell dose may be important, and it's good to analyze centers data as well as multi-center from India to see somewhere between 5 to 10 per 8 or 6 into 10 per 8, something like that is a better dose to be capped at. And so that sufficient CD34 cells are given. So obviously that should be good dose, but at the same time capping the T cell.
Ajita, he's done some cost analysis on abatacept. So Ajita, this is 1 lakh for one dose, one dose, right? If you can text, I think you may not be able to speak out here. So anyways, I think that there was a question in the chat box. I just have a comment on this question, which is asked on tacrolimus and cyclosporin. Yes, the data with tacrolimus is slightly better than cyclosporin overall. Survival graft versus host, has been kind of overlapping. So there's no advantage of one or the other. A little bit edge on tacrolimus or cyclosporin. I think Prasad shows those curves. But we have to be just cautious here again. We don't have IV tacrolimus. And with oral tacrolimus, it will take 5 to 7 days to reach a steady state. So that means, you may not be therapeutic, or sometimes, you may be toxic also, subtherapeutic also, for a good 5 to 7 days when the graft has gone in. So that's been one of the limitations of our tacrolimus use in India. Cyclosporin is IV available. You can quickly achieve levels, you can check them quickly, and that is one of the practical problems with using tacrolimus in our setting. And hence again, interpreting the data which has been kind of published on the West, we have to also understand the logistics which we had to, which are different here as compared to what they had in the data which was presented. So I think with that, we will probably conclude this session. It has been a really great session on a very important and very difficult topic, I would say. one of the most dreaded complications, which we all transplanters hate to see, and hate to discuss also probably. But it's good to have a great session, and Prasad did a wonderful job in summarizing all of that in 30 minutes, 40 minutes, and quite good discussion followed with practical day-to-day questions related to the graft-versus-host disease. So with that, we'll take your leave, and we will we will see you again next month, last Tuesday of the month, with another important topic. And we'll see you again. Thank you very much, Prasad, for your time. I know there must be time difference. It must be past midnight for you now. And thank you, Vipin, Garima, Vinay, for putting this very important discussion together. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Good night.
Good night.